and the American Society of Addiction Medicine. He has been credentialed as an American Academy of HIV Medicine Specialists and has received national recognition for his work serving the rural community of Austin, Indiana, with limited resources. Dr. Cooke's work has been covered by CBS, NBC, PBS, the BBC, USA Today, the New York Times, NPR, and others. He was named Family Physician of the Year by the Indiana Academy of Family Physicians in 2016 and won the National Physician of the Year by the American Academy of Family Physicians in 2019. He joins the ranks of 2 U.S. Surgeon Generals and a former Secretary of the U.S. Department of Health and Human Services by receiving the Ryan White Distinguished Leadership Award in 2019 as well. Dr. Cooke lives just outside of Austin, Indiana with his wife, Melissa, and 6 children, and he is here with us today to present Canary in the Coal Mine, which coincidentally is in conjunction with the launch of his book. So without further ado, take it away, Dr. Cooke.
Thank you, Luke. I appreciate that. And yes, today the book came out. And so if you're interested in that, you can learn more either on Amazon, you can search for the title, or at the book website, which is canaryinthecoalminebook.com. I'm going to read a little bit from the book from time to time. And I'm going to skip this video here at the beginning. Let's see if I can do that. And read a little bit from the introduction as we start. So the COVID-19 outbreak that gained momentum throughout the United States in 2020 highlights how socioeconomic and racial disparities impact the health of people. This fact goes beyond genetics or limited access to medical care. The roots of disease can consistently be traced along the tragic history of toxic stress experienced, often generationally, by marginalized and impoverished people. My patients taught me just how devastating the health impact of socioeconomic hardships can be. In March of 2015, I was the only doctor in Austin, Indiana, a city of 4,300 people, in Scott County, just off I-65 between Louisville, Kentucky, and Indianapolis, when it became ground zero for 2 unprecedented healthcare disasters with roots in the 1980s. One was the national opioid epidemic. The other was the worst recorded HIV outbreak among people who use drugs in the nation's history. These 2 deadly epidemics had been brewing alongside one another for decades until they boiled over in Austin. Reporters flocked to Scott County, and I told them that this wasn't a freak occurrence. The conditions that made Austin ripe for this crisis existed in towns all across America. We had to act immediately and decisively to prevent other communities from being harmed. I told Dean Reynolds from CBS News as we walked through the hardest hit areas of Austin, I've described this community as the canary in the coal mine. This could happen anywhere because we are all Austin, Indiana. So I grew up in Southern Indiana, and my family came out of Appalachia, just like many of the families that migrated to Austin came out of Appalachia. We followed the hillbilly highway, looking for greater opportunity and hope. And my family, unfortunately, only found poverty and heartache on the banks of the Indiana side of the Ohio River. My family was surrounded by poverty and substance use disorder, but somehow my mom was able to rise above that. She had people who kept showing up at the right time to honor her, existence as a human being. They saw her as a person with potential. And even though she dropped out of high school at age 16, which was very common for my family, she actually had gone further in school at the age of 16 than most people in my family had gone. Even though she dropped out at 16, she met my dad who loved her and introduced her to his family, who was much more caring, didn't have the substance use disorder part. He joined the military. She moved on to the base and found structure and a lot of people that was willing to invest in her and my dad, both really. And so after serving in the military, my mom went back to graduate from high school, ended up graduating from nursing school, and eventually graduated from medical school and became a physician. Now her sister traveled a different course. she didn't have anyone that stepped up in her life and try to show her the compassion that she deserved, just like my mom deserved. And all she met was heartache. She got pregnant for the first time at 13, lost that baby, was pregnant a couple more times, lost those children, never really found somebody to show her the love that she wanted. And she ended up dying of a drug overdose at 39. What I discovered was that growing up in poverty myself, I wanted to do something really significant with my life. I grew up in the church and wanted to follow my faith, to do something for other people. But what I found was that just trying harder wasn't getting me anywhere. My teachers kept telling me to try harder. My coaches kept telling me to try harder. But I didn't know what that meant. I wanted to try harder, and I felt like I was trying harder. But I didn't have the tools and the resources and a lot of times the opportunity to make that effort count in a way that allowed me to become more successful. So moving on into college, I finally started connecting with people from higher socioeconomic classes than myself, who understood what it meant to take notes, to study, and to do well in school. And I started, hanging out with them, going to study groups with them. And, through that association, I started understanding how to take notes, how to study, and my grades suddenly started getting better. And my junior and senior years of college, I got all straight A's, went on to medical school, graduated with honors. And so all that effort that I had been putting in that wasn't really getting me the success that I wanted or felt that I could achieve, all of a sudden started mattering when I had the tools and the resources and the opportunity for all that effort to finally make sense to me. After graduating from residency, I set up a family medicine practice in the rural town of Austin, Indiana. Again, 4,300 people. There hadn't been a doctor there since the mid-1970s. And what I found was this perfect storm of a lot of prescription drug use, poor people that were disconnected, living in isolation without transportation or access, public policies that was really harming people, where people couldn't have the services that they needed and deserved, testing, access to harm reduction. And then we saw the hepatitis C and HIV infections come into the community, which really devastated the community. So Austin is located in the northern part of Scott County, which is located in southern Indiana, just between Louisville, Kentucky, and Indianapolis. Scott County did not have access to addiction services, just like much of Indiana. Indiana ranks near the bottom in the country for access to addiction specialists, and Scott County ranks even worse than that. Public policies, again, very much a lack of access to harm reduction. Public education really pulled away from anything that was helpful. Abstinence only, no condoms, no clean syringes. People didn't understand how hepatitis C and HIV was spread even. So we were starting behind the curve there. So when the outbreak occurred, we were dealing with a large percentage of a very small population that was spread out across a rural area. Estimates were that about 15% of the population were participating in injection drug use. And the biggest obstacle that we found was these were people living off the grid that did not want to be discovered. And so trying to find them and connect them to resources was very challenging and the biggest obstacle that we faced. Early on in my practice in Austin, I met a young woman named Samantha. Samantha came to me with low back pain after having back surgery, and she wanted a local doctor that could help her with her pain. And she was already being prescribed Norco and wanted to figure out how to live without pain. And so I agreed to take her on. and to try to work with her to get her to the place where she wouldn't need the pain medicine anymore. She agreed to go to physical therapy, all that, did a drug screen, only the Norco showed up in her urine. So we started working together. But several months later, urine drug screen came back and it showed that she was taking several other controlled medications. And so this was 2006 or so. And the standard practice at that time, what I was trained to do, was dismiss somebody from your practice that was abusing prescription drugs. They weren't, worth the time and effort, basically is what we were told, and that they would have to hit rock bottom before they ever wanted help. So I did what was kind of standard practice. I sent her a letter in the mail, letting her know that she had broke her contract with me and that I would no longer be able to provide services to her. So I cut her off from medical services at a time when she really probably needed help, and she was no longer able to go to the doctor. And again, I was the only doctor in Austin. So looking back on that, it seems like kind of a cruel thing to do. And what we know is that life has two directions. It either moves upward towards success and transcendence and actualization, or down towards disease and early death. The top part is based off of Maslow's hierarchy of needs. And if somebody is not seeking these higher needs up here, it's probably because their lower needs are not being met. So if somebody doesn't know where they're going to live, where they're going to sleep tonight, where their next meal is coming from, whether they're safe or not, they're probably not going to care about themselves or others and start seeking higher purposes in life. So if somebody doesn't seem to be trying, it may be just that their basic needs aren't being met, and not that they're not willing to try. And so coming down here and trying to meet their needs for safety, their needs for humane housing, transportation, food, shelter, safety, may actually allow them to be able to start caring for themselves and their community to the point where they're able to look like they're trying again. And on the other side, if you have a lot of social distress, toxic stress, adverse childhood experiences, we know that this disrupts the neural development of a child, leading to social, emotional, and cognitive impairment, leading to risky behavior, leading to early diseases, disability, social problems, and eventually early death. So life either can spiral up or spiral down based on the foundation that our life is built on. And that's not something that we choose. We don't choose where we're born, who we're born to, what circumstances we're born into. Those decisions are made for us, and we bear the consequences of those. And so focusing on people's safety needs and basic human needs can allow them to do better in life. What I found early on in Austin was that people were suffering from diseases that they shouldn't have been suffering from because they didn't have access to medical care. An example of that was cervical cancer. And no one should ever die of cervical cancer. It's completely preventable if we're screening for it and intervening. But I unfortunately diagnosed multiple women with late stage cervical cancer and ended up watching them suffer and die unnecessarily just because they lacked the access to the screening services that they deserved as a human, right in the middle of the richest country in the world. So this is in a way inflicting violence on people. It's harming them, and violence can be direct, visible, as somebody goes up and hits somebody else, or it can be invisible and embedded in the structure and the culture by not engaging people in healthcare, not getting them the insurance that they need, the transportation that they need, the access that they need. And this sets up a life where there's this health gradient that makes it very difficult. And somebody might be trying really hard to be healthy and to do well, but they're pushing this big boulder up against poverty and poor housing and unemployment and a lack of food and nutrition and lack of education, environmental hazards. So somebody might be trying really hard, but still suffering the consequences because of a structure that's set up against them. And what I've come to believe is that there are certain requirements in order for somebody's agency to really matter, and the decisions and the choices that they make in life to result in good outcomes, because people only have the ability to choose from options that are available to them. So they need to have their basic human and safety needs met. Socioeconomic circumstances and opportunities need to be in place that allow them to be able to make healthy choices. And then they need to access to resources to make those healthy choices. And when all those things are in place, all of a sudden health, prosperity, and well-being become possible. Well, one night after this part's from the book, and I'm just going to read a section from the book. So I worked in the emergency department, and one night after seeing a steady stream of patients with chest pain and abdominal pains, coughs, and minor injuries, a panicked young lady rushed up to the registration window, eyes wide in panic and screaming hysterically. "My sister needs help. She's too weak to get out of the car." Both of my nurses immediately rushed out and pulled a very frail 20-something female from the car. When we moved her from the wheelchair to the stretcher, she began groaning loudly and frantically flailing her arms around. We had no idea what was wrong with her, but based on the track marks we saw running up and down both arms, we had our suspicions. The nurses began to hook her up to the monitors and searching her arms for IV access. "What's her name?" I asked, checking the young woman's vital signs. A quivering voice from the corner of the room said, "Amber, she's my sister." I called her name loudly and asked, "Can you hear me, Amber? What's going on?" "Stop," she replied as she slapped at the nurses trying to help her. I leaned in and turned her head to look into her face. "Amber, look at me. You're at the hospital and we're trying to help you. We need to know what's going on. Are you in pain?" "Everywhere." She nodded and groaned. Exasperated, one of the nurses looked at me and said, "She's used up all of her veins. We're not getting anything. Her blood pressure is 64/30 and her pulse is thready," said the other one. I put my stethoscope to her chest and listened to her racing heart and rapid breathing. "She needs fluids now," I instructed. "We can't get IV access, Doc. She's blown all of her veins," the first nurse repeated. I thought for a second. This young woman was critically ill and we had to have IV access to save her life. Amber's sister stood quietly in the corner, looking frantically from one face to the next. "I've been wanting to try that new IO device," I blurted out. "Now's as good a chance as any. Let's break it out." An interosseous infusion is an efficient way to rapidly give a patient fluids and medications without IV access by essentially drilling a needle directly into the leg bone and forcing fluids into the marrow. It's only used in emergency situations like this one because it's extremely painful. I had undergone a bone marrow biopsy myself when I was 15, and even with a local anesthetic, it was excruciating. The nurse handed me a small electric drill similar to one that I used on weekend projects around the house, and I attached a large needle to it. Holding the drill in my right hand, I felt the bony landmarks just below Amber's left knee with my left hand. Satisfied I had the correct place, I forced the needle through the skin, down to the bone, and pulled the trigger. Amber unleashed a blood-curdling scream as the nurses strained to hold her still. Her sister cried out in horror, her hands covering her mouth and nose. We quickly began to push fluids into her. It's what her body needed, but it didn't stop her from fighting back against the pain. The nurses held her down as she thrashed about, moaning as the fluids pushed its way into her bone marrow, causing waves of pain throughout her body. Unfazed, I ordered 2 full liters to be administered as quickly as possible. "Is something wrong?" her sister pleaded from the corner. "Why is she in so much pain?" "Bone is exquisitely sensitive," I quickly answered without turning to look at her. I was too busy monitoring Amber's vital signs flashing ominously on the monitor and processing my next steps. Based on everything I was seeing, she was severely dehydrated and likely septic. Probably, I concluded, from the consequences of using dirty needles while injecting drugs. "She shouldn't have used up all of her veins," one of the nurses murmured knowingly to the other nurse. As the fluids continued to flow in, Amber's heart rate and blood pressure started to improve. She began I began pressing below her right collarbone, searching for the landmarks where I would place a central line. This means inserting a very large, several-inch long needle about the size of a cooking thermometer into her chest to pierce one of the largest veins in her emaciated body. This would allow more reliable intravenous access for fluids, antibiotics, and other medications that Amber needed. She winced and groaned as I sterilized and prepared the area under her collarbone. Then, just as I was about to insert the needle, a voice broke my concentration. "Don't you even care that you're hurting her?" I had forgotten that Amber's sister was still there. I turned to face her. "What? You're hurting her and you don't even seem to care." She wiped away the tears streaming down her face. "I heard you say that you were looking forward to using that drill on her." I was dumbfounded. I was doing everything possible to save her sister's life. I'm sorry," I said flatly, looking to keep the spot I had identified on Amber's collarbone sterile. "We're doing everything we can to stabilize her." "Yeah, but that's my sister," she shot back, tears flowing. "You're not treating her like a person." That comment hit me like a bucket of water. I looked into Amber's eyes. Her sister was right. Amber was not just some drug addict suffering the consequences of irrational behavior. She was not a test dummy on which we were practicing our treatment algorithms. Amber was a person who was obviously cherished. She was this tearful young woman's sister. Reality's veil lifted ever so slightly, and for a brief moment, Amber became my Aunt Sally and her sister my mom. One day while I was in college, my mom had raced to the hospital after being told her sister had been taken there after overdosing. My mom met Dr. Graves, a physician whom she had worked with. With sorrow in his eyes, he told my mom that despite his best efforts, my aunt had died. "We had to call it," the doctor told her. To call it sounds so cold given what had actually happened. Mom had worked enough codes to know they had stripped her sister naked to expose any injuries and to allow unimpeded access to her body. They shoved a tube down her throat to breathe for her. They performed chest compressions, which, if done correctly, broke ribs. This was a violent, undignified way to die, just as drilling into Amber's leg bone was a brutal way to stabilize her. Yet neither Dr. Graves nor I had any choice. My breathing choked on a wave of emotion that washed over me as I imagined my mom pleading with me to treat her sister like a person. This young woman had every right to hold me accountable for my lack of compassion. Composing myself, I tried to explain, "Your sister desperately needs fluids, and this," I pointed to the intraosseous sticking out of her leg bone, "this is our only option right now. Can't you at least help her be more comfortable?" she asked. "Of course," I said, making sure that I was speaking gently. I turned back to the nurses. "Go ahead and give her 50 micrograms of fentanyl." Then I looked at Amber's sister and said, "That will help ease some of the pain." Amber almost immediately relaxed, and I went back to inserting the central line. But her sister's admonition continued to echo in my mind. So what we know are there are certain community factors that are vital to people doing well, and they're represented in this graph here, and include a thriving natural world, a place where people can get outside and exercise and meet other people and explore the outsides, reliable transportation, humane housing, meaningful work, and lifelong learning, and then, of course, their basic needs and health needs being met. And in the middle, that holds all of this together, is a sense of belonging and a sense that they're able to make a difference in their communities. So meaningful work, lifelong learning, humane housing, reliable transportation, civic muscle. So just trying harder isn't enough. I keep this broken off piece of lawnmower cord in my office to remind me that just trying harder doesn't accomplish our goals. Other things need to be in place in order for our goals to be accomplished. And that that goes for our patients and our people in our community as well. For us to just say that they're not trying hard enough isn't honoring them as a person. First, we need to listen to their stories and understand where they're coming from. And it may be that their basic human needs and safety needs aren't being met, or they don't have reliable transportation or housing, or they've never had the resources and tools that they needed or the opportunities. They might be trying really, really hard, but never being able to succeed because the right combination of factors aren't available to them in their life. So a few years later, I met Samantha again in the emergency department. And this is another section from the book. So I went down the hallway to check on Samantha. Samantha had come in for abdominal pain, and I hadn't seen her since that time I just sent the letter to her in the mail. So I was trying to take care of her and find out what was going on with her with the abdominal pain. So I went down to check on her, and when I got there, she was asleep. The man who had come with her quietly rose from his chair and with an expectant look on his face, motioned for me to follow him into the hallway. "What can I do for you?" I asked. "Here's the thing, Doc," he whispered. Then he glanced back over his shoulder to make sure Samantha was still sleeping. "Sam hasn't been doing well." He pulled a crumpled up envelope out of his back pocket. "She's been carrying this around in her purse for a little over a year. It's addressed to you, but she couldn't bring herself to send it to you. I think you should read it." I didn't know what to say or do. I reflexively took the envelope. It had Dr. William Cooke written on the front, along with my office address. I thanked him, though I wasn't sure why, and we shook hands. Once I got back to my desk, I opened the handwritten letter, and Samantha began by apologizing for what she had done. And basically, the letter described a childhood filled with toxic stress. She never felt like anyone loved her. She never felt safe. And at some point, somebody gave her a pill that took all that away. It made her feel okay for the first time in her life. It gave her the sense of well-being that she had never felt in her entire life. She didn't know what it was at the time. She just knew it helped her feel better. So she continued to take those, only to later find out that they were prescription painkillers. But then she wasn't able to stop taking them because she started going through withdrawal. Severe, flu-like symptoms with diarrhea and vomiting and just feeling like she wasn't able to rest. Insomnia that lasted, 7 to 10 days. So she would get into a few days of it and then always relapse back on the pain pills. So when she came to me, she was really wanting to try to get off of them and was willing to work with me, but she had gone through some stuff and relapsed and used some other things, and I found out and kicked her out. So when she decided that she wanted to, apologize and see if she could come back to see me, but she was afraid to send the letter to me, but basically wanted to come back to see me to help her get off the pain pills and to do better in life, basically. And I felt really good about that. I thought, here's a second chance at helping somebody that I had just kind of coldly dismissed before. So I was feeling pretty good about that. And after tending to a few other patients, I sat back down at my desk. My shift was almost over. I glanced over at Samantha's letter and allowed myself to relax a little with the thought that I'd have a second chance to show her the care I didn't show her the first time. Just then, my nurse poked her head around the corner and said, "Dr. Cooke, the patient in 8 scans are back. I thought you might want to look at them before you leave." I smiled. "Thanks," I told her, and I pulled up the results on my computer. No, God, this can't be right. I leaned in and took a closer look, but it wasn't necessary. The scans clearly showed a massive tumor beginning in Samantha's cervix that had eaten all the way through her rectum, completely obstructing it. The report was long, but the words that jumped off the screen at me were metastatic cervical cancer. I felt sick. Given the size of the tumor, odds were it had been silently growing there for years. If she had been receiving regular medical care, a routine pap smear could have identified it early enough to spare her suffering. She could have gotten treatment and she would have been okay. Now, she probably only had 6 months, maybe 9 at the most. What made things even worse was knowing I had participated in shortening Samantha's life by cutting her off from preventative care. How was that any different from the structural violence system that limited life-saving and life-affirming care for the most vulnerable? So it really upset me that I participated in cutting her off from medical care. And I vowed that I wouldn't do that any longer. But what we saw coming was this tsunami of suffering that nobody was really willing to hear and listen to. In 2011, we locally saw a large increase in overdose deaths, along with abscesses and increasing rates of hepatitis C and endocarditis. In 2012, Reuters released an article nationally showing that Austin was being damaged, along with a bunch of other rural communities, by Opana. This was a national article showing that Austin needed help, yet nothing was done in 2012. From 2011, 12, 13, 14, Scott County was in the top 3 in the state of Indiana for new hepatitis C cases. And hepatitis C is a harbinger for HIV. Anywhere that there is hepatitis C spreading in a community, HIV is soon to follow. The state health department in 2012 issued a warning saying that if something wasn't done, we would start seeing increasing cases of HIV. Nothing was done. And so towards the end of 2013 and 14, we started seeing, but we didn't know, transmission of HIV in the Austin, Scott County communities. There wasn't any testing going on, so we didn't know this was going on. And you can see here the new cases that were going undetected until right here at the end of 2014 into 2015, when testing started occurring, and we slowly caught up to this tsunami of disease that was ravaging Austin because we hadn't paid attention. And here you can see the new cases of HIV. We finally established a local HIV clinic in my office right around April. And then a week or two later, Scott County was able to open the first syringe services program in the state. In between treating people, testing them, and getting them linked to care, and providing access to sterile syringes so that people weren't sharing syringes any longer, you can see the curve rapidly leveled off from there. Unfortunately, what we know is that the incidence of HIV in the community was almost 5%, which was one of the highest in the world that year. So from the time I opened my practice in 2004 up into 2015, there'd only been around 5 documented cases of HIV. And then, starting in 2015, within a year and a half or so, we had over 240 cases. And it represented a third of all the new cases of HIV in the state. And it increased the total number of HIV cases in Indiana by 20%. So this was a significant outbreak that we saw coming, that could have been prevented, that we just didn't do anything about until it was too late. It was young people, mostly injection drug use, split pretty evenly between male and female. It was a new outbreak because only 3 people had developed AIDS with a CD4 count less than 200, and it was directly related to injection drug use and co-infected with hepatitis C, as over 92% of people were co-infected. The consensus was that even if we found the people living with HIV, because of their lifestyle, they wouldn't take their hepatitis C and HIV medications. They were being dehumanized, and that led to assuming that they were unwilling to engage in care. Again, people were looking at them and saying, they're not trying. They're not trying, they don't care. Even if we provided them medicine, they don't care enough to take their medicine. They assumed that they were lazy, we were criminal, that they were degenerate and unintelligent. Sadly, people were even advocating withholding life-saving interventions from people like Narcan, naloxone. However, by working with people that inject drugs, that are marginalized in general, that the world views as being less than or unwilling, I found that they're really no different than you or me. When approached with respect and compassion, virtually all people are willing to take responsibility for their own health and the health of their communities. The key is providing people a safe bridge to that opportunity, access that feels safe to people. I'm going to skip some of this because of time. So what works is combining prevention, which we didn't do, with treatment and access to recovery. And there's a whole host of amazing groups that came in to really help us be able to achieve this. So Maytech is a training center that's located all across the country in different regions, and they provide training for treating HIV and hepatitis C. So they were really helpful for me and my office to be able to develop our ability to take care of people, because me just trying harder wasn't going to accomplish anything either unless I had the tools and resources that I needed to be able to provide this service. So Maytech, GLATSI, which is kind of the Maytech version of addiction medicine. So they provide training and resources to be able to provide addiction services to people. There's Project ECHO, which I'm a huge advocate of. I was able to participate in a Project ECHO program where I was these people here that you have local primary care teams that meet with specialty teams to learn about particular diseases like HIV or hepatitis C or addiction or rheumatology, diabetes. There's all kinds of different ECHO projects that are available for healthcare teams to learn from specialty teams, so that those primary care teams can then provide that service directly to their patients, and it amplifies this knowledge down to the patient level. And so instead of patients being required to travel sometimes long distances to see a specialist, for example, in the state of Indiana at the time, if the patient had hepatitis C, they were required to see a gastroenterologist or an infectious disease doctor, which meant that they had to travel long distances to see these specialists. And these specialists were very limited in their ability to see people. But by getting primary care teams involved, they were able to provide that service locally. And that model works very well. I'll skip that one. So we had collaborations with recovery centers like Wooded Glen and the Centerstone Recovery Center for men and women. Indiana State Department of Health came in, helped a lot with getting access to funding and resources. AIDS Healthcare Foundation, largest HIV provider in the world, came in and helped us develop mobile teams. We listened to the people suffering and invited them to be part of the solution. And over time developed a recovery community organization called Thrive. So these are people with lived experiences. Many were injecting drugs a few years ago, and now they're part of the solution. They work alongside us as peer recovery coaches to help us engage people in care and provide them the services that they need. So we had a lot of services. This is Tom Cox from GLATSI. He introduced me to a concept called ROSC, Recovery-Oriented System of Care, that listens to the community and develops a community-specific definition of what recovery looks like for that community, because every community is different. It's going to look different in an urban setting than a rural setting. It'll look different between a white evangelical setting and a Hispanic, setting. Each community is going to develop a different model for what recovery looks like. And I always like to honor Tom Cox for introducing me to that and helping us develop that here in Scott County. So a recovery-oriented system of care, it's evidence-based, it's SAMHSA funded, and it just brings everyone in the community together to learn from the people who are affected. And in the realm of addiction, obviously, you're listening to people either in recovery or still actively using drugs to develop actionable solutions that work for that particular community. Our ROS program was incredibly effective. And I'm going to skip the video just for time's sake. We learned a lot about harm reduction, and we had harm reduction workshops where we taught community leaders. So the county commissioners participated in our workshops. The City Hall county people participated in the workshops, and people with lived experiences. The sheriff and the deputies participated in our workshop just to learn what harm reduction is and that it's evidence-based. We connected with faith groups to develop feeding programs like for Food for Our Souls and recovery centers at H2O. And faith groups can show an amazing amount of compassion to people and just love them and be there for them. Can be a source of stigma too. So, just trying to teach faith communities to connect with people wherever they're at and just love them there and help them get access to the safety, their needs being met, the resources and opportunities that they need, and then trusting that they're going to make those healthy decisions for their life and just be there for them, to support them and love them through that. What we know is that there have been studies now looking at Scott County, and based on what the studies have seen, over 90% of the HIV cases could have been prevented just by simply screening and linking people to care and providing harm reduction strategies. But again, that opportunity was lost and our community suffered. And we're the canary in the coal mine again. And this is happening in communities all across Indiana, all across the country. We recently have witnessed the most concerning, what the CDC calls the most concerning HIV outbreak in the country right now in West Virginia, as a result of them closing their syringe service program over there. So what works is combining biomedical interventions with behavioral interventions and then structural interventions. So structural interventions first, looking at decreasing inequity, working to develop better laws that protect people's rights to treatment, and then better educating the public and the youth. Again, people didn't know how HIV was spread when this outbreak occurred in 2015, and people were afraid that they were going to contract HIV from just casual contact. So one of the first things we had to do was educate people on how HIV is not spread, that it's not in tears, it's not in saliva, it's not in sweat. So you don't have to worry about touching someone. You can show them compassion and love. You can touch them without being afraid of that. And then decreasing stigma and discrimination, of course. Biomedical, increasing access, protecting moms and newborns through increasing access to addiction services like buprenorphine, but also prevention programs, helping women choose when to get pregnant by increasing access to women's health and contraception, and then protecting the newborn by getting HIV medications to moms who may be HIV positive. Screening, harm reduction, MAT, all important in the biomedical interventions. And the behavioral interventions, educating people. There's a lot of really great evidence-based, school-based programs that use like dialectical behavior therapy to engage in youth that may have been suffering from chronic toxic stress, adverse childhood experiences, to help build resiliency in their life, to decrease their risk from using drugs. Increasing access to therapy, cognitive behavior therapy, increasing access to employment, lifelong learning, and then of course, peer support and social support. What happened when we focused on this patient-centered approach in Scott County was really a beautiful thing occurred. In just a few years, the number of people in recovery increased by over 1,000%. Our collaborations grew stronger and allowed us to see this rapid decrease in the number of HIV cases that we were seeing. Of course, the syringes that were being distributed went up initially as people learned that they could trust the people at the syringe service program, but then they leveled off and started to go down because more and more people were entering into recovery, as you can see here. We have the best viral suppression rate in the state. That means that they can't spread the virus. And the reason we have the best viral suppression rate in the state, I believe, is because we've honored them as people, trusting them to make healthy choices when they are given the opportunity to access care in a way that feels safe to them. So the syringe services program helps us stay in contact with them. Our mobile teams go out of the clinic to find them where they're at and just meet with them and build relationship and trust. And they take their medicine. They've proven the people wrong that said that they wouldn't be willing to engage in care. People have made a healthy choice to use the syringe service program. As I've told people over and over again, people who use drugs don't have to use a syringe service program to use drugs. They can use drugs without going to a syringe service program. It's a brave thing to do to go to a syringe service program, admit that they're using drugs and admit that they need help. That's a healthy choice. And providing people access to healthy choices isn't enabling them to use drugs. Again, they can use drugs without going there. It's enabling them to access help. Again, people only have access to the choices that they have access to. If we restrict access, we're dooming them to have only access to unhealthy choices. So this is a healthy choice. Providing them access gives them the opportunity to make a healthy choice. Indiana, unfortunately, has led the country in new hepatitis C cases, but in every county that has a syringe service program, we're seeing decreasing cases of hepatitis C. Scott County is a great example. In 2015, there was 243. In 2018, only 58. HIV cases have been, again, declining. We only had one new case of HIV last year. This is what happens when the whole community comes together and provides services in a way that feels safe to people. And we just trust that we aren't over the community trying to press a agenda onto the community. We're just part of the community, working with other people in the community that want to see their community do well. And when we do that, we can all work together to build a healthy and thriving community together. And this is a list of many of the people that helped over the last few years. I'm sure I've forgotten some, and I've asked for forgiveness for those that I've forgotten. And thank you. This is Dan Bigg. He was really important early on in helping us develop that harm reduction strategy of embracing any positive change. And he was a champion for community distribution of Narcan, really pioneered that. So I always want to include him on there too. If you want to learn more, the book is available now, either on Amazon or at the website there. It's much more than just addiction and HIV. It's about just connecting with people that we might not understand, who might appear different than us, that may look different, act different, believe different. But when we pause and just try to connect to them on a human level, oftentimes we'll find that they're no different than us. They're just trying to get by in a confusing world and do the best that they can. And by working together, we can all of us together, we can all do better by working together. So I'll pause there and just see if there's any questions. Would love to answer some questions.
Thank you very much, Dr. Cooke. It looks like we have one in the chat here. I recently heard that the needle exchange program in Scott County was discontinued. What impact do you anticipate from that decision? And is there anything we can do to provide data to help reverse that decision? I think you've covered some of this, but just wanted to point it out.
Sure. So yes, they did vote to close the syringe service program. We're very thankful that they gave us until January 1st. So right now it's still active and still able to work with the clients of the syringe service program. Data was provided. The former Surgeon General Jerome Adams, who was the health commissioner while the HIV outbreak was occurring, was present. Our health commissioner, Dr. Box, was gracious enough to show up. The director of the HIV division of Indiana Department of Health was there. Our county health officer, a neighboring county health officer, our emergency department director, the director of the EMS, myself, people in recovery, Thrive. We all showed up and we all told our stories. And the data wasn't going to move them because this really falls down on what somebody believes about people who use drugs, unfortunately. And we are looking at other options. We're not going to just sit still and not provide the care that people need. So we're looking for options. The story isn't over. We'll see what happens, but we've got some things in the works.
Here. We have a note of appreciation here from Candy. She lives in Scott County. And then Anna asks, even with the evidence behind syringe services programs, the stigma seems to be stronger. How do you propose we educate officials on the importance of syringe services programs?
Yeah, I think that this falls down into a belief, an ideology. And data doesn't really affect that. Anytime you have people operating within a stressful environment, the tendency is to fall back on your core belief system. We saw that in COVID with the mask situation. People who, it was a very stressful situation, people losing their jobs, people afraid of the disease, of dying, that sort of thing. And the people who really believed that we all need to take care of each other, they fell back on let's wear masks. Those that believe that we all have individual liberty, which is a valid concern and a valid value that we hold as Americans, the people that really champion that, they fell back on that, said, no, you can't tell me what to do. So the data is there. It's presented, it's overwhelming. It's over 30, 40 years. Scott County is a real world example of how well it can work with only one HIV case last year, declining hepatitis C cases, exploding numbers of people in recovery. But it comes down to that belief system. And so what I think moves that are stories. People with lived experiences willing to allow their stories to be heard, so that we can build empathy and understanding. Because one of the foundational characteristics of American culture is that we show compassion to one another. We're willing to defend each other's right to life. And so by sharing these stories and humanizing people and showing that, this is an 8-year-old girl who was hooked on drugs by her mom or dad, who grew up, hooked on drugs, didn't have safety, didn't have humane housing, didn't have access to things, who's now a young adult. And it's easy to stigmatize and have a lot of bias against a young adult making a bad decision. But when we see that decision wasn't made by them originally, they didn't choose where to be born, who to be born to, what circumstances to be born in, what obstacles were going to be in their way. They didn't choose any of those things. And I think when people start hearing those stories and how people are willing to seek help when it's offered to them, I think that moves people, and understanding that people only have access to the choices that are presented to them. If in a community there's no access to transportation, then we can't expect them to be able to get to the hospital or get to a doctor's office unless we provide that transportation. And so when people start understanding that access to choice matters, and hearing their stories of overcoming just incredible odds when they do have access to the resources and the opportunities in a way that feels safe to them, I think those stories can move people more than the data itself. People on the fence, yeah, the data might sway them. But the people that are firmly on the side of that this is a personal choice, this is a character flaw, these are people that are just bad people that need to go away and die or get locked up. They need to hear real life stories that humanize the person. They need to stand, face to face with somebody and have that person really demand their humanity to be seen and show that they're not a bad person. They're just a person in need. And when that happens, I think that human compassion, if it's there, might rise up and overcome their bias.
I was curious, have you, I mean, you talked about a bunch of community partnerships and collaborations in your presentation. Could you elaborate potentially on any cooperation and collaboration that you've had maybe with local law enforcement or the criminal justice system?
Yeah, so the Sheriff's Department partnered with us and Thrive, the recovery community organization, to when they respond to a drug overdose or a person in crisis, that person is offered access to a recovery coach through Thrive. And the recovery coaches have tablets now that they carry with them. And if that person who's having a crisis wants help, that help is available right then and there by somebody with a lived experience similar to them that can understand and empathize and relate, that can build some trust with that person. They would have access through the tablet to myself or one of my providers to potentially provide MAT for a few days to bridge them to get into a clinic or to get into a inpatient recovery center that are becoming more available. So the sheriff, his team will call Thrive. Thrive will go out, meet with the client, connect them to services through the tablet, which I think is a really innovative approach. And we've helped hundreds of people already through that program. So that's just one of many.
Any other last minute questions here? We have just a few minutes remaining. All right, I don't see any raised hands. Thank you so much, Dr. Cooke. And everybody, the book is available at all retailers online and probably even in some local bookstores. Am I right?
Yes, that's correct. And I'm happy to come to any churches, any community organizations, businesses. We can set up Zoom calls, or I can come there to do, a book club. People can read the book. We can talk through the themes. It has a lot of stories that I just was talking about that hopefully can humanize people with different lived experiences than many. But I'm happy to set up meetings with other groups and organizations and churches to talk through this more.
Great. And I just want to note also that the recording of this webinar will be available on the Indiana Rural Health Association YouTube page after this. And that is our time, everybody. Thank you so much. I'm going to go ahead and stop the recording now.